Okay, so keep your knee locked straight and don't let me push the leg down. Let's try this side. So keep the knee locked straight, don't let me push down. Hey everybody, Jamie Raymond here. In this video we're going to talk about Psoas inhibition and specifically how to diagnose Psoas inhibition using a basic manual muscle test. Psoas inhibition is something that I find is super important clinically and yet honestly goes unrecognized by most practitioners. The reason it's so important has to do with its three principal actions. So Psoas obviously is a hip flexor, but it's also a low back stabilizer and a hip joint stabilizer. So consequently, if you have Psoas inhibition, you lose some hip flexion, you lose some spinal stability, and you lose some hip joint stability. Clinically, Psoas inhibition can factor into anything from low back, hip, quad, knee pain all the way down to the Achilles, pretty much anything in the lower half of the body. At our offices, we find that well over half, if not more, of incoming patients with these type of complaints have Psoas inhibition. I recommend testing for Psoas inhibition on anybody with any lower body complaint. In other videos, we'll go about how to treat Psoas inhibition, but in this video, we're going to talk about how to test and diagnose for it. All right, so let's roll with the actual muscle test. Conventional Psoas muscle test looks something like this. You're 45 degrees in flexion, a little bit of AB abduction, and you stabilize the opposite hip. So right off the bat, we're going to do things a little bit differently. We are not going to stabilize the opposite hip because I think this just kind of cues the patient that, hey, we're about to have a contest and I want you to push as hard as you can, and that's actually not what I'm looking for. More importantly, I'm looking for a reasonable amount of pressure by keeping the knee locked straight. That's almost one of the most important pieces of this whole thing. If they bend that knee just a little bit, it introduces quad and they can very easily cheat. I also don't have them abduct at all because if you have adductor inhibition, that can show up as weakness. That's not really hip flexor, it's more adductor. So we do straight flexion up at about 45 degrees, keep the knee locked straight, and I kind of visualize, instead of pushing straight down, I kind of visualize an arc. And that's kind of my line of drive, is arcing down towards the table. So I'll run through a couple of these like in real time. Actually, I kind of know which side is weak, so I'm going to do the good side first. Okay, so keep your knee locked straight and don't let me push the leg down. Good, and I get my weight up over the leg. One more time. I always repeat about 2 or 3 times. If there's any question, so push again. So that's a reasonable amount of pressure for her. I feel a catch and I don't feel a break. Let's try this side. So keep the knee locked straight. Don't let me push down. Okay, and so with the same amount of pressure, there was no catch and it broke. Let's see, I use about 50-50 this hand versus this hand, or maybe a little bit more towards the ankle hand. If they're a strong individual, for the average person, maybe 50-50. Half the point of this hand is just monitoring the quad. Sometimes I'll just keep tapping it like this, so hardly any pressure with this hand. If you see quad cramping, sometimes they'll tell you, sometimes they'll reach down and grab their quad. That's almost a dead giveaway that they have Psoas inhibition, and even though they're keeping their legs straight, they're trying to pull in the quad, and the quad is being overloaded and kind of spasms. So if you see quad cramp, that's almost a sure thing it's inhibited. So one of the reasons I repeat the test is if there's any question, inhibited muscles tend to get weaker each time you test them. They give out easier. Go ahead and hold and push again. Okay, go ahead and hold, push again. So like by the 3rd or 4th rep, that inhibited muscle is just giving out. Now, if it's a unilateral weakness and they have a good side, if anything, the good side almost tends to get a little bit stronger as you do a few reps. It kind of warms up into it. Push again. Do one more. So within reason, unless you totally fatigue them, a typical response is the inhibited side starts breaking easier and easier, and the good side, if anything, gets better. I think the most important thing out of all this is to be objective. Try not to have any preconceptions about what you're going to see or not see, and just use good form on your end and be objective with it. So that's what Psoas inhibition looks like. If you have any questions, feel free to leave them in the comments section and I'll get back to you. I think you'll find that testing for Psoas inhibition and identifying it in your patients really helps to flesh out the clinical picture. If you do decide to start testing, I would love it if you'd post some of your results in the comment section. For instance, take the next 10 low back patients or hip pain patients, test for Psoas, and tell me how many you find have inhibition. So, for instance, 4 out of 10 or 5 out of 10 or 6 out of 10. This would help me come up with a better idea of the prevalence of inhibition. That's all for now, and thanks for watching.